Thanks, Fabian. Thanks for the kind introduction. Thanks, Harry and Adam, for organizing and inviting me to speak again on combination therapy. So I'm going to try to go through some general concepts, I guess, about combining therapy, and we'll focus on primarily not on NUCs. Here are my disclosures. And so what I'll first start with is just talking about some of the options to combine. We've obviously discussed those and some rational approaches to thinking about how to combine agents. So obviously we're all well aware of the different approaches, either on the viral side or the immune targets. And I would say that there's lots of different possible ways to mix and match these things. And I would say people have tried different approaches. I'm going to try to just talk about a few ways you may think about combining them. So the first is sort of, you could think about the type of target, whether you're going to put together an antiviral versus immune targets, and then whether you're combining each with the other. Or you could think more about the pathway that you're focused on, whether in either the life cycle itself or about controlling replication, and that may combine these things. And I would probably prefer the second. I would say that the thinking about the type of target is a little bit like this, where we have the virologist and the immunologist duking it out and arguing that really one approach is better than the other. And I think there certainly is obviously some value to having a lot of expertise on both sides of this argument, and we may well need both. But I think when we think about these things, we probably should be thinking more about the second approach. So you could, if you took the target-based approach, you could sort of say, we're going to start with two antiviral targets that either approach the same target or a different target, and you can see some examples of those and how you might choose to combine them. Or you could have different immune targets or a antiviral target with an immune target. And of course, this is just double combinations. You can get into triple combinations. It gets more complicated. But this is really just putting the things together without really much rationale to it. So I think a more rational approach to it is to try to think about the different ways that you might think about controlling either the life cycle or getting control. And I've just broken them into three general concepts. So the one where you have a common pathway, and this would be what I call the plug the leak approach. The second would be where you have different but complementary pathways, so that you sort of, and I call this the enabler approach, where you have one drug that's helping the other drug. And the third would that there might be some unrelated pathways, and that's either because you observe maybe an unexpected thing that ends up working, and I'll show examples of these, and I would discourage this, it's because it's the what we have approach, where people combine things just because that's convenient and easy to do. So let's start with the common pathway or plug the leak approach, and Rich Colono, I think, gave a very good explanation of sort of the concept here. And although I'm not really going to spend most of my time talking about NUCs, the obvious one here is to talk about the combination of NUCs with something else that blocks replication. And so you see, as Rich nicely showed, antivirals do not block replication 100%, and that's why we don't get cure with NUCs alone. And if you add something either upstream or downstream, you increase the efficacy, and you probably reduce the risk of resistance primarily to the downstream agent. If you combine them, if you add it on, it might also be to the upstream agent, but primarily that's going to be more for the downstream agent. And the simplest example of this is adding a capsid assembly modulator to a NUC. You have less substrate, less pregenomic RNA getting into capsid, so you have less chance of NUC resistance, as well as Rich mentioned. For capsid resistance, if you start with suppressed patients, there's just less probability of resistance occurring. So this is very simple, that if you look at where you have the NUCs working very far downstream, and then if you add in a capsid, it's upstream, so that the effect further downstream is going to be augmented over either one of those approaches alone. And that's sort of a simple and straightforward approach that your readout of looking is going to be amplified by combining these two things. And you see this initially, again, as Rich showed, that you get a better HBV DNA decline when you add the CAM to a NUC, and then probably more convincingly, and I think this is the more impressive part of this, is that you're also getting to a lower nadir, where you start with patients that still have detectable HBV DNA despite long-term NUC monotherapy, and then you add on top a CAM, and you can see that these patients become undetectable by a more sensitive assay. Now, of course, whether that's actually blocking 100% of replication is not clear, and I think that's going to be a recurring theme, that as you get to however you combine these agents, figuring out what each agent is doing depends a little bit on your ability to measure that outcome, and this becomes a challenge when you get to very low-level replication, particularly when we're limited by looking in the blood. So other sort of plug-the-leak approaches is you can combine other agents, and again, we've heard about this approach of combining an siRNA siRNA with a capsid assembly modulator. So here the idea is blocking core protein upstream with the siRNA, so blocking production, you have fewer capsids, and then so you should end up with a greater effect by blocking encapsidation. And again, this probably just enables some of the PK that we're seeing that you're not getting 100% block with almost any of these agents. So again, if you block the transcript production here and then you add in the capsid, then again your output, your downstream readout is going to be greater. And so here's some data supporting that. You heard that there's trials upcoming. These are more in vitro data, but looking at the combination of a type 2 CAM combined with siRNA. And what you see on the right is the synergistic plot showing that you do see synergy here, and you see that when you take either of these alone, so you see the synergistic effect is primarily on HBV DNA because both things affect that, whereas the surface antigen effect is primarily driven by siRNA here and not so much by the CAM. So you again can distinguish as you'll expect to see differential effects of the two different approaches. So the another example of this would be to go even one step further upstream and combine an entry inhibitor with a capsid. And here, blocking entry will prevent infection of new cells and thus cccDNA formation. And as we've heard, the secondary and hopefully or perhaps more important mechanism of the CAMs is that they also block the recycling of capsids and the uncoating of new capsids infecting cells. So in both situations, you're going to reduce cccDNA formation. And so this, again, might be a very attractive combination, which at least as far as I know has not been proposed yet. So if that's we move down to the next approach of this kind of enabler concept, where here the idea is that agent A enables the action of agent B. And this would either be taking away something that's blocking the action of agent B, or perhaps stimulating agent B directly or indirectly. And so here I think this is where you're likely to be combining. This is probably more relevant on the immunological side in trying to enhance effects of some of the immune targets. And so I'm just going to give a few examples. Again, none of these are from human clinical trials, but there are some from preclinical data. And so most of you will have seen these data that were presented last year at AASLD from Uwe Protzer's group, showing in either an HBV transgenic or the AAV HBV mouse model that when you use siRNA to knock down antigen levels, you see that enhances the effect of a therapeutic vaccine, which both things alone had a fairly modest effect, you see here, but then and then when you knock down siRNA, you get a deeper suppression of S antigen, but it's actually only when you first knock down siRNA and then give the therapeutic vaccine that you get these off-treatment clearance, at least in this mouse model. So showing that the taking away this block of having the S antigen preventing therapeutic vaccine effect. Now I think we heard Andrew present the nucleic acid polymer data, and I think it's certainly interesting to see these flares and impressive to see the S antigen decline. The argument that these are reflecting immune reconstitution, I think, is really interesting, but I really do think this needs to be proven, and I would just sort of make this case for everything, that we shouldn't assume for any of these things that something that could be happening is happening. We really need to understand more clearly whether these flares are actually immune restoration and whether it's leading to immune clearance. It's certainly a reasonable hypothesis. It's also a very testable hypothesis, so we really need to collect the data here. So on the other side, that's taking away the antigen block. The alternative would be taking away something that's happening here. You're looking at immune exhaustion, and these data were published a few years ago showing that if you use a PD-1 inhibitor and then add in a vaccine, again, you basically make your T cells more responsive to the vaccine. So you can see that this is all in the background of a nuke, but really when you combine the vaccine after an anti-PD-1 is given, you can see that there are more durable T cell responses, and more importantly, that's the only group that led to clearance, again, in this woodchuck model, which is necessary here because you need a competent immune system. But I think just really highlighting the fact that taking away this inhibition can enhance the function of a second agent. And then finally, again, another immunological approach using the opposite side, where you use a second agent to stimulate or augment the effect. So in this case, again, using a therapeutic vaccine. And this vaccine has reasonable efficacy at low and moderate viral loads, but when you get to high viral loads, it really doesn't work very well. So the concept here, again, by Protzer's group was to add a CpG into this, which is a TLR9 agonist, and this really induces an immunogenic microenvironment in the liver, and with the concept that when this is given shortly after the vaccine, so you see that the prime and then the boost vaccine is given and CpG is given here, that what you see is that this increases your both the number, and so really the red bars are when CpG and vaccination are given, and you can see that both the polyfunctionality and number of T cells is increased. These are core specific, it's a core vaccine, and you can see that the declines in E antigen, S antigen are greater, leading to greater ALT flares, and then actually most importantly, greater clearance of core expressing hepatocytes in the liver. So really just showing the concept here of using something that's stimulating the vaccine by adding in a second immune stimulant on this, in this case on the innate side. And on the flip side, you might use something, combined therapies, where you're sort of putting on the brakes here. So if you think about CAR T cells, where you have you're combining an HBV antigen with T cell stimulatory antigen, and you get activation that's not HLA restricted, which has been very effective in some cancers. But if every T cell reacts with every HBV antigen in the serum, you may have a very aggressive response, which could be potentially dangerous. Or you could also have rapid exhaustion and loss of the effect. So both scenarios are possible, and ideally you might combine a non-specific immune activator like a CAR T cell with something that dampens the antigen load so that you reduce the effect, you reduce the exposure, and therefore either enhance the effect to prevent exhaustion, but also dampen the effect so that you don't get this massive destruction of the liver. And so this is just, again, this sort of enabling concept where you're combining two agents that use different mechanisms but sort of help each other. And then finally, the sort of unrelated pathways, and we'll just look at these two briefly. And I was actually very happy to hear that Stefan also said that he didn't know why this happened, because I was concerned. I was waiting to load up my slides because I wanted to see the answer and move this into one of the other categories. But this Recludexb combined with interferon, and really highlighting the fact that this group led to S antigen decline. So understandable effect on HDV, but I think it was, at least for me, this was perhaps the most surprising part of this study, without an obvious explanation why this entry blocker should enhance the effect of interferon. So these are relatively unrelated mechanisms, and you see this quite significant benefit of the combination. And so I think this is something that when we see this, we should now investigate to try to understand why this is happening so that we can add to our list of rational combinations. And this, in a sense, this made sense because this was being done for Delta, but it may inform what we do for B. I would really sort of discourage this approach that putting together our leftovers sometimes works reasonably well, but it really is not the best strategy. And I would say, having worked in the Hep C field for a long time, this was done all too frequently, where companies were very insistent on using their own, in quotes, assets, and sometimes to the detriment of drug development, and arguably in the end to patients, because there were long delays in getting the optimal regimens that ultimately did end up becoming the standard of care. And I would discourage companies from doing that. So fortunately, there is some good collaboration, and many companies have multiple different approaches to consider. But remember that if yours is not the best, work with someone whose is, rather than persisting at what you currently have in hand. And then finally, this is, of course, just thinking about two different approaches. Now, I think a lot of people think if you ask people how should you combine, this is usually the sort of vague answer that people give: something that suppresses DNA, something that reduces antigen load, and then something that stimulates the immune system. Obviously, you can, once you start to get into 3 or more combinations, you start to get into a very complicated matrix, and this gets more complicated. But at least I think this general approach is still probably attractive. So just to summarize, there's many approaches to combining therapy. I think on the viral side, this plug the leak is really, I think, the common approach. The different pathways and enabling is probably more relevant to immunological targets, and then unrelated pathways can, I think, teach us a lot to hopefully better understand why we should combine things. And when we do this, it's really key to collect data with tools to measure activity of each component of the combination. And it was discussed today more more than once that assay sensitivity will be a major issue, but trying to figure out what each part of a combination regimen is doing is really important. And arguably, figuring out what the best scientific approach here is going to be the easy part, and Dr. Peters is now going to tell us how you put them together and figure out how to study them in the right patient population, which might actually be more challenging. Thank you very much.